Welcome to The Explainer. Today we are talking about a procedure that for the longest time was considered, well, basically medical suicide: lung transplantation. We're going to look at how surgeons finally cracked the code on an operation that for decades just seemed completely and utterly impossible.
Okay, so here's how we're going to break this down. We'll start in the operating rooms of the past, where, believe me, failure was pretty much the only outcome. Then we'll get into the key breakthroughs that turned everything around. We'll see how a really complex system decides who gets a second chance to breathe, and we'll tackle the single biggest problem, the critical shortage of donor organs. And finally, we'll actually step inside the OR for the surgery itself and then explore the lifelong commitment that comes after.
To really understand where we are now, you have to go back to a time when the idea of replacing a human lung, well, it was pure science fiction.
You know, in the middle of the 20th century, this was the Mount Everest of surgery. Doctors were transplanting kidneys with some success, but the lung, it's so delicate, it's complex, it's always exposed to the outside air. It just seemed like a peak that nobody could climb.
This timeline really tells a story of incredible hope followed by just crushing despair. That first attempt back in '63, the patient lived for 18 days, and that proved, okay, technically this can be done. But what came next was basically a dark age for the field. For 15 solid years, surgeon after surgeon tried, and they all failed. Patients were surviving for just weeks, sometimes only days. By 1978, it was considered so deadly that the entire medical community was basically ready to give up on it for good.
So what was the problem? It was one single, devastating complication: the airway connection just would not heal. It would break down, it would leak air and infection, and the patient would die. Think of it like trying to connect two delicate, wet paper straws. And to make it worse, the very medicine you're giving the patient to stop them from rejecting the new lung is also stopping those straws from sealing together. This one tiny point of failure was the brick wall that stopped the entire field cold for almost 2 decades.
So how did they finally solve this thing? Well, it wasn't one magic bullet. It was a combination of 3 crucial innovations that finally turned the tide.
And you know, this is how so much of medical progress actually happens. It's not one single eureka moment. It's about solving multiple tangled-up problems all at once. All the gears had to click into place together. A new drug, a smarter surgical trick, and a better way of choosing patients. You needed all 3 to finally make the machine work.
First up, the drug. Cyclosporine was an absolute game changer. You see, the old anti-rejection drugs, these high-dose steroids, they were a classic double-edged sword. Sure, they stopped the body from attacking the new lung, but they also completely stopped that delicate airway connection from healing. Cyclosporine was different. It could powerfully suppress the immune system without that devastating side effect.
Second, a really clever surgical move. Surgeons figured out that the donor's airway was dying because its own blood supply had been cut. But they realized if they kept that donor airway incredibly short, we're talking just a couple rings of cartilage, it could actually borrow enough blood flow from the patient's side to survive and heal properly. Just an elegant solution to a really deadly problem.
And third, they just got way smarter about who they operated on. A team in Toronto realized that patients with pulmonary fibrosis, people whose chests were small and stiff, were actually better candidates to start with. This created a more stable environment for the new lung, especially compared to the huge, overinflated chests of emphysema patients.
So you put all 3 of those pieces together: the new drug, the better technique, and the smarter patient selection. And boom, 1983. A 58-year-old man with pulmonary fibrosis gets a single new lung, and he survives long-term. This wasn't just another attempt. This was the moment. This was the proof that launched the entire modern era of lung transplantation.
So the surgery was finally working. But this success created a whole new and really difficult ethical problem. When you have way more sick people than you have available lungs, how on earth do you decide who gets to live? As you can see, the need for new lungs comes from a whole range of really devastating diseases. The biggest piece of the pie, more than a third, goes to patients with obstructive diseases like emphysema. But a huge number are also for people with fibrotic or scarring diseases and septic conditions like cystic fibrosis.
For years, the system was simple: first come, first served. Whoever had been on the waiting list the longest got the next available lung. But this created a really messed up situation. It actually favored patients who were healthier, the ones who were stable enough to just sit on the list and wait, while the much sicker patients who desperately needed a lung right away, they might die before their number was called.
So to fix this, in 2005, the system was completely torn down and rebuilt with something called the Lung Allocation Score, or LAS. And it's a fascinating concept. Instead of just asking who's been waiting the longest, it asks a much smarter question: who will benefit the most? The algorithm calculates two things: how likely you are to die soon without a transplant, and how likely you are to do well with one. The goal is to give that precious organ to the person who will gain the most life from it. It's a huge shift from just waiting in line to actually maximizing survival.
Now, the LAS definitely helped allocate lungs more fairly, but it couldn't solve the single biggest bottleneck in the whole system: the profound, crushing shortage of donor organs.
And this is the statistic that just floors me every time I see it. The lung is an incredibly fragile organ. Because of trauma or infection or fluid that builds up around the time of brain death, only about 20% of lungs from otherwise perfect organ donors actually meet the strict criteria for transplant. A staggering 80% of lungs have to be turned down.
So to fight this shortage, transplant centers have had to get a lot more creative. They've carefully started to expand their criteria using what are called extended criteria donors. This means they might now accept lungs from an older donor, or someone with a limited smoking history, or maybe lungs that have some minor issues on a chest x-ray. These are lungs that would have been automatically thrown out just a decade ago. It's a calculated risk, but it's saving more lives.
But here's where the technology gets really cool. This is ex vivo lung perfusion, or EVLP. This machine is, well, it's basically an ICU for a pair of lungs outside the human body. It keeps them warm, it pumps a special nutrient solution through them, and it even breathes for them. This gives doctors a precious window of time to assess, to clean out, and to recondition these borderline lungs, turning many of that rejected 80% into life-saving gifts.
All right, so let's get into the surgery itself. What actually happens in the operating room? Well, it's an incredibly complex procedure, of course, but it really all boils down to making three very precise connections. Think of it as a surgical symphony in three parts. First, the airway. That's the historically tricky connection that lets you breathe. Second, the pipe for blood going in. That's the pulmonary artery, which brings blue, oxygen-poor blood from the heart to the new lung. And third, the pipe for blood going out, connecting the veins that carry all that fresh, red, oxygen-rich blood back from the lung to the heart. It's that simple and that complex. Connect the airway, connect the blood going in, and connect the blood going out.
That surgery is this huge monumental event. But for the person who gets the lung, it's really just the beginning of a brand new, lifelong journey of medical care.
You see, getting a new lung isn't a cure, it's a trade. You're trading your end-stage lung disease for a new set of chronic but manageable conditions. This means taking a whole cocktail of powerful anti-rejection drugs every single day for the rest of your life. And those drugs suppress your immune system, which makes you vulnerable to infections. And there's always the risk of rejection, so patients have to be watched constantly, including regular procedures where doctors put a tiny camera down into their lungs to make sure everything still looks healthy.
So when you step back and look at the whole story, it is just a marvel of modern medicine. It went from an impossible dream to a life-saving reality. But as science solves old problems, new frontiers always open up. We've gotten so much better at preventing that immediate, acute rejection. But the big, long-term threat is chronic rejection. So the next great challenge, the next Everest to climb, is figuring out how to achieve true tolerance, how to finally convince the body to accept this new organ for good, without a lifetime of powerful, risky drugs.